So thank you so much for your presentation and previous colleague to invitation here. It's very interesting precedent intervention as regarding the social ambient aspect to influence the development, no? Addiction therapy, addiction, addictive behavior, and also psychiatrics. So go fastly to present, if you want, my study with Daniele Nacca, that was a colleague of Istituto di Psicopatologia in Rome, in near Mediterranean land, no? So we are a patient private clinic, currently professor of School of Specialization in Psychodynamic Psychotherapy, and I'm going to show you a naturalistic study that was done on a sample of 519 subjects who applied for assistance because of a disorder of pathological addiction. We made an assessment at their first visit using an approach based on international guideline for both addiction medicine and psychiatric disorders. So, the sample to whom the study relates was composed of 410 males and 109 females who were followed by our psychiatric services in the period of time between 2000 and 2005. Our aim was to study and detect comorbidity in drug addiction in a therapeutic community. So, first of all, here are some important preliminary data with the highlights of our study among our 15. This is a pointer? Yeah? Good. 519 subjects. 43% of them abuse alcohol, 27 cocaine, and we try 41 of them have family member with some mental disorder and 43% family member with addiction. Also, furthermore, 11 of our subjects have an attention deficit of hyperactive disorders and 57% exhibit criminal behavior. So this is a preliminary study. The sample is a middle sample, 500, and probably after this we organize a statistical analysis of our data in real world. So you can see the Gaussian curve is predictable, and the average age is particularly relevant. Indeed, other studies highlight the same average age for the request of assistance. The age of 30 can be considered a crossroad age, no? For addicted patients who don't manage to quiet their addiction during their youth, so from 13 until 29 years. Fail to have prospect for their future and consequently feel a higher familiar and social pressure to change their lifestyle. So in this diagram, you can see the distribution between gender. It's also consistent with the literature data, 79% versus 29 male, female. So, and perhaps also Dr. Nova Volkov of the National Institute of Drug Abuse agrees in considering youth as the onset age. So, before we see the most interesting presentation regarding the development in land of paradise, no? Of a teenager, particularly this aspect, this influence. So the late onset are interesting and should be studied in regards to comorbidity, because One of the brain areas still maturing during adolescence is the prefrontal cortex. The part of brain, the prefrontal cortex was this, as you can see. The parts of brain that enable us to assess a situation, make sound decisions, and keep our emotion and desire under control. The fact that this critical part of a youth brain is still a work in progress put them at increasing risk for making poor decisions, such as trying drugs or continuing to take them. Also, introduce drugs during this period of development may cause brain change to have profound and long-lasting consequences. So, the vulnerability of the ventral tegmental area already developed in an adolescent, as you can see, no? The nuclear accumbens and this communication regarding the mesolimbic, amygdala, and prefrontal cortex are most interesting because it's already mature, the mesolimbic activity, and overly activated in case of gratification in the phase of still incomplete development of the prefrontal cortex. So it's the same for the onset of daily use. The passage from abuse to addiction is strictly linked to the visited subjects who come for an addiction disorder. The state of abusive borderless, if compared with addiction, as the outcomes show, and as finally acknowledged in the DSM-5. For a simple naturalistic study, we can see the entry-level substance emerge from the real world. The first, THC, followed by cocaine, opioid and alcohol, but also we can consider 8% compared to the abuse, the polyabuse. It's more complex because challenging abstention and treatment. So alcohol is present as abuse and sometimes ignored by clinicians. We can see 56.3%, no respect 77%. So for example, the weaning from a substance can often produce an abuse of alcohol at the end of treatment. You can see that subjects under methadone maintenance treatment often combine alcohol abuse with a similar percentage. Some considerations is necessary regarding the information given to patients about the risk of alcohol consumption. In other words, in the real world, treatments are often done with agonist opioids with a negative doping, but the alcohol consumption is not investigated, as outlined, for example, by the therapy with methadone, and then maybe at the weekend by the binge drinking. So, this data alike can change the diagnostic and therapeutic approach when you can see regards a family member with a mental illness, yes, 41%, respect no, it's half part. Why? Because familiarity is an important risk factor for the later development of psychiatric disorders, especially if elicited by the use of substance. So also we can try how addicted person often tend to stay with their family of origin rather than to build up their own life. Good middle, only 13% respect our sample declare low quality of family relationship. As regard the diagram refers to psychological status in the age of development. So obviously limitation is represented by the modality of assessment, retrospective, anamnestic, interview, written, psychometric assessment. So it is a clinical assessment in private patients. So we can see extrovert and normal is more representative respect other difficult, for example, learning disorders, emotional, like ADHD or ADHD, quiet also, but more interesting regard, this is okay, there's a home situation you can see before. So, for example, in this respect, if have you ever received psychiatric treatment, no hospitalization is not possible, often not completed by operators, detailed clinical interview. But in this, we having more samples that have a lifetime psychiatric events in a sample of addicted. And this diagram confirms polydrug abuse, real risk shouldn't be underestimated. A serial polyabuse with the diachronic distribution of substance within the polyabuse, the real polyabuse. Other substance during abuse, cocaine principle with THC and alcohol, also benzodiazepine and heroin that show more development in the last year, respect last decade that was slow represented. Substituted the dependence. So these are, for our researchers, very interesting because psychological status during the first examination. Because it's interesting to know that the visiting of a patient with euphoria and hypomania is very rare. Because the visiting at the counseling service is often caused by anxiety or depressed and mixed mood disorders, or for perhaps oscillating mood is represent a cyclothymic, also dysphoria. But if you see mania, euphoria like hypomania, not really represented. So also we can see in our sample no body principal medical illness represented respect this fact, because probably impact was the sample outpatients, clinical private outpatients, so not ACV, HIV, and finally, okay, psychiatric disease. We can see the bipolar disease 2 or no other specified bipolar disease was more representative. Also respect in subtypes mixed states or subtypes bipolar 2. Also bipolar 3, because we can see this aspect, see about a few minutes. I would like to present you the temperament according to Akiskal. So we can see the hyperthymic and the cyclothymic represent more respect melancholic and irritable, but this aspect regarding the temperament respect the states, this trait versus state before. And then here are data about the bipolar spectrum in our patients. Less serious types are prevalent due to the kind of counseling service given to our patient. It should be noted, bipolar disorder 1 and 2 generally correlate in a different way depending on the type of admission. It is a show how the outpatients are almost more than twice the inpatients. The prevalent disorder in outpatients are BP2, 73%, and taught in a low percentage, the BP3 induced by substance and or antidepressant also, where there is a negative history for a mood disorder, probably that explodes or come out elicited by the use of substance or antidepressives. So this aspect in the real world and clinical is more represented because not all cocaine addicts have manic episodes in taking a substance, because if it is always cocaine addictive behaviors with the cocaine staying in hospitalization to emergency, in fact notice it in our experience. With hypophoria, we mean the state in which patients, in absence of a substance, has irritability, abstinence from dopaminergic down. This is a more representative principal number of a sample. And they're having not also irritable, but also abulic, apathetic, so are irritable patients that could see particular in cocaine abstinence patients. So, in summary, we have seen the prevalence of polydrug abuse in the bipolar spectrum and the risk caused by a wrong diagnosis. The data brings out a prevalence of bipolar spectrum disorders of medium severity in outpatients, while in the literature data on inpatients with high psychological severity prevail. The percentages of psychiatric diagnosis recorded are congruous with other published epidemiological works, giving importance to an undoubtedly exploratory study made on a quite relevant sample compared with other studies made on quantitative smaller samples. These people have been visited after their request to be helped with their addiction. Alcohol consumption stands out significant, and it is present across the board, as in subjects receiving agonist for opiate addiction. The prevalent input substance are THC and cocaine, while in every use, alcohol, cocaine, and THC are prevalent, without forgetting the poly-use abuse. Other data give an account that is not only psychopathological and about the style of consumption of substance, but also social, giving an idea the social context of patients lives, family and society. So a problem in this field is the lack of political intervention and the lack of interaction between psychiatric and addiction services. It's necessary to avoid any kinds of stigma and continue with the new studies from the real world. Thank you for your attention. Any questions?